Hey all, this is Eric Christensen, the host of the Real Life Pharmacology podcast. I've got a great episode for you today. I hope you enjoy it. And please feel free to reach out, reallifepharmacology.com. Give us a comment. Let us know what you like, what you don't like. We'd love to hear from you. Here's the podcast. Today I'm going to break down metformin for you. With its mechanism of action, it reduces hepatic glucose production. That is the primary mechanism of action. I think the most important one that you need to remember. Oftentimes, if you're doing an exam, you might have kind of a matching type situation or a multiple choice. This one is very unique in that it reduces hepatic glucose production. It is from the class of medications called biguanide, which maybe I shouldn't say medications because metformin is really the only one that is available. Of course, this is a diabetic medication. By reducing liver glucose production, we reduce blood sugar. We can help improve A1C. We can help manage our patients with diabetes. Major, most common side effects: stomach upset, so nausea, vomiting, and diarrhea. Maybe diarrhea being the most prominent there. So you definitely need to watch out for this when patients first initiate it. You're going to have to look at each patient individually, see how bad those stomach upset problems are, and work with patients because it is a first-line medication in diabetes. Very, very common medication for sure. So with that, make sure that the starting dose is appropriate. Another little trick or quirk that I've seen come into play is sometimes patients will tolerate the extended release a little bit better as far as stomach upset and that type of thing. So that might be a potential option if the immediate release is being used, maybe switching them over and trying that. But again, I've definitely seen inappropriate starting doses in patients as well. B12 deficiency is possible with metformin. There's definitely an association between lower B12 levels and metformin. So this is something to keep in mind. If you've got a patient with symptoms of possible B12 deficiency, they've got, let's say, anemia, maybe they've got some CNS changes, maybe they've got neuropathy type pain, that might be a good time to take a peek at that B12 and make sure we're doing okay there. Kidney function. So metformin isn't typically classically associated with worsening kidney function. The problem or the challenge with metformin is when a patient's kidney function gets worse, this drug can accumulate. And we run the risk of lactic acidosis, which is very, very severe, very, very serious, but very, very rare with metformin, and it's much more common in patients with significant kidney disease. So kind of, the ballpark target I look at this point with the best evidence we have is about 45 mils per minute on a, GFR, for example. If you got patients below that, it's probably going to be a little bit dicey to use metformin. If you've got patients above that, typically that risk of lactic acidosis is much, much less. So keep that in mind when you've got a patient with poor kidney function, or if you see a diagnosis of CKD, chronic kidney disease, in stage maybe 3, 4, or 5, metformin's probably not going to be appropriate in the majority of those situations. Now, again, we've got to look at clinical factors and, what other diabetes medications can we utilize and how high are their blood sugars and so on and so forth. So it's not always a 100% end-all be-all, but overall, keep a close eye on that kidney function because the drug can accumulate and cause this severe problem with lactic acidosis. Metformin does not do much for stimulating insulin production. So what this means is a good thing for patients in that it typically doesn't cause much for hypoglycemia or severe hypoglycemia in patients who are on metformin alone. Okay, so that's definitely a good thing in metformin's favor. Another potential positive for metformin in our classically overweight type 2 diabetes patients, medication does tend to be weight loss or weight negative. So that's a nice added effect, whereas some of the other medications like sulfonylureas and using insulin can definitely contribute to weight gain. With that GI side effect, administration procedure is pretty important for patients. I have seen patients take it without food and tolerate it okay, but definitely it is best and ideal to administer that medication with food to kind of help minimize some of that GI upset concern there. With the GI upset, keep an eye out for kind of that polypharmacy cascade. So if you see that metformin started and you run into a patient that's reporting that they're having stomach upset or heartburn or any sort of kind of GI symptoms, and you see medications added to help treat those GI symptoms, like patients taking an H2 blocker or a PPI, or being prescribed those type of medications, thinking that it's a new diagnosis. So definitely keep an eye out for GI side effects and diarrhea for sure. They are really problematic with metformin. Again, kind of summing up, metformin, first-line agent for diabetes, definitely can do a nice job of lowering blood sugars, lowering A1C. Rarely does it cause hypoglycemia by itself, so that's definitely a positive. Keep an eye out for B12, and importantly, we need to really assess patients with poor kidney function and make sure that their metformin is appropriate. Hope you enjoyed the podcast today. Feel free to reach out, reallifepharmacology.com. Send us a message, and take care, and I hope you guys have a great rest of your day.